Hello, everyone, and welcome to today's virtual panel discussion brought to you by the Georgia Association of Healthcare Executives. My name is Ricardo Rivera, and I'm your session host representing the National Office of the American College of Healthcare Executives. Before we get started, I'd like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session unless there is an active discussion, at which point you may unmute yourself to talk. You can submit questions through the chat function at any time. This event is being recorded and will be available for viewing in the ACHE Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will have their 1.5 face-to-face credits applied within 2 weeks from today's event. We do encourage you to complete the evaluation for this event. The evaluation link will be posted in the chat box soon, so please visit the link before we close out today's session. Now to begin the session, let me turn it over to GAHE President Trent Lind. Trent, I'll turn it over to you.
Hey, thank you, Ricardo, and thank you all that are attending our session today. Very great topic for us, telemedicine and the healthcare delivery system. I can tell you that I've been on a couple calls this week just around our telemedicine services. And so I know that we rely heavily in our healthcare environment when it comes to telemedicine, and really just amazing, especially through COVID, the evolution of what we've seen with telehealth and telemedicine across our delivery system. So looking forward to hearing from some of our foremost experts in the field. Can't put on events like this without amazing sponsors, and I say that every session. GAHE has a big mission to fulfill, and sponsors like Wellstar, our platinum sponsor, really do appreciate what Wellstar has done to help us put on events like this, and certainly support GAHE's mission. Gold sponsors: Piedmont Healthcare, Metro Atlanta Ambulance Service, Vocera, and Sound Position. Thank you to our gold sponsors. And then our silver sponsors, DT Spade and SSR. Again, thank you to all our sponsors for what you do to help support GAHE. Upcoming events, you can see here, we have continued to go virtual for the remainder of this calendar year. We've got events in October and November and beyond. So stay connected with us so you can attend these events. We're trying various ways and avenues to keep you informed and give you opportunities not only to stay connected and network with your colleagues, but find ways to gain credits and stay at the top of your game when it comes to the healthcare, your healthcare knowledge. And you can register for all these events at gahe.org. And then I mentioned staying connected. Sebby Browning, our fearless communications lead, helps to provide support for a lot of different avenues for you to stay connected, whether through our website, through Facebook, through LinkedIn, or through our Twitter service. And get involved. It's interesting. GAHE is a volunteer group made up of a board and various committees you can see here on the screen. So a lot of different ways to get involved. Our communications committee, our career development committee, fellowship advancement, membership growth and satisfaction, diversity and inclusion, our newest subcommittees, physician executive group, which we call PEG, programs and sponsors, just a lot of different ways that you can get engaged and involved and also network at the same time. And you can do so if you have an interest by connecting with Bruce Lloyd, our executive director at admin@gahe.org. In today's session, worth an hour and a half, 1.5 credits face-to-face, which we'd love to be able to offer these. We really appreciate ACHE for allowing us to put on sessions like this where you can actually gain face-to-face credits. Today's program, again, as I mentioned, a very timely topic, telemedicine and the healthcare delivery system. Appreciate our moderator, Lloyd Sermons, who's the director of Southeastern Telehealth Resource Center. And here's a little bit about Lloyd, who will have the opportunity to introduce our panelists and moderate our session. Lloyd Sermons received his associate's degree in computer science from Columbus State University in 1998. He immediately began his IT career working with TSYS of Columbus, Georgia, where he worked as a mainframe programmer. He worked a number of years with Columbus Regional as a systems analyst before entering into full-time ministry, where he served in pastoral leadership for nearly 14 years before joining the GPT team in August of 2010 as the BTOP project director. He completed his BS degree in interdisciplinary studies from Liberty University in 2009. With over 10 years of experience in the telehealth field, Lloyd brings a sound knowledge of IT solutions, along with strong leadership and communication skills as the director of Southeastern Telehealth Resource Center. There's a reason I rely on my IT team, because I am maybe not as literate as individuals like Lloyd. I'm really excited to have Lloyd here with us today and helping to moderate our session. And Lloyd, I'll let you take it over.
Absolutely. Thank you, Trent, for that. And I always tell people when I sit and I kind of watch people introduce me and kind of think back over my time, I tell people, from a technical standpoint, when it comes to computers, technology is what it is. And I tell people if I can't fix it, then I'll just lay hands on it and pray for it. So, kind of got all the bases covered there. So, but as Trent said, my name's Lloyd Sermons. I'm the director of the Southeastern Telehealth Resource Center. And, I know you're probably wondering, well, what is the Southeastern Telehealth Resource Center? Our acronym that we go by is CTREC. You can go on to the next slide here. This kind of, gives you a little bit of an idea of who we are as a Southeastern Telehealth Resource Center. We are federally funded, and we are funded for the purpose of advancing telehealth and telemedicine across the country. And then we also cover territories, the U.S. territories as well. I'm not the only telehealth resource center, as you can see from this map here. We're funded by the Health Resources Service Administration, or HRSA, through their Office for the Advancement of Telehealth. And so there's actually 14 telehealth resource centers around across the country that are funded. And 2 of those centers are national organizations. And you have the Center for Connected Health Policy that really deals with policy at a national level. They do a lot of good work in keeping their finger on the pulse of what's going on, with the policies around telemedicine, CMS, and they also do a 50-state Medicaid report as well. And they keep kind of an update on some of the policies at the state level too. Another national resource center is the TTAC, or the Telehealth Technology Assessment Center. And just as their name says, they deal with technologies around telehealth and telemedicine. The remaining 12 resource centers basically cover regions of the U.S. and territories. And so, as you can see there, for my organization, we're funded to provide services and technical assistance to Alabama, Florida, Georgia, South Carolina. And then with this most recent round of funding, we now cover the territories of the U.S. Virgin Islands and Puerto Rico as well. So we'll be, kind of doing some work with those territories. And so we pretty much have the entire U.S. covered. You can move on to the next slide. So what do we do as telehealth resource centers? I mentioned that, we're funded by the federal government for the purpose of advancing telehealth and telemedicine in our region. And really what it boils down to is we're a free resource for those who are wanting to get into the telemedicine space, or maybe you're in the telemedicine space, but you have some questions. Maybe you want to expand. Maybe there's questions around some policies or reimbursement and things like that. Those are the type of things that we kind of we try our best to track and keep our finger on as best we can. As you can imagine, covering multiple states, it can be a very difficult task. But we do other things as well. We work with people like, coming up, I've got someone in Alabama, and we'll go on site and do a site survey for them. They're wanting to do some telemedicine. And and they're wanting to start a program where they connect out to some FQHCs. So we'll go in and we'll do a site survey with them, with their facility and some of their some of those FQHCs, program development. But really, I think the driving force for us, though, is, we're that resource that people can kind of pick the phone up and call if they have a question. And being federally funded, of course, we're free. We have resources on our website. Those are resources that are free resources. There's some patient-facing telemedicine type of resources that are there, and all those are free. So, but I'm glad to be here today, and looking forward to the conversation. I think we have a wonderful panel. As we were talking about earlier, we have kind of the A team today. Got a great group of panelists. We have Kevin Adams, who with Atrium Health. We have Rick Morrell with Arrow Health. Dr. Diego Reyno, who is with Intercept Telemed. And we're just gonna, kind of, drive through some questions today, and hopefully you guys will kind of get a good understanding, of where we are, and sometimes, somehow maybe where we're going in the future when it comes to telemedicine. So I'm not going to spend any time really introducing these panelists, because what we're doing is we're giving them some time, as we move on here. We're going to give them a little bit of time just to kind of talk about themselves. And what I kind of ask them to do is, talk a little bit or give a snapshot, I guess, of their journey. So, so I'll go ahead now, and Kevin, just turn it over to you and let you go through a few slides.
Thank you, Lloyd. Appreciate it. Thank you for having us, and I'm looking forward to the conversation. So I'm Kevin Adams. I'm with Atrium Health, and I'm part of the small but mighty virtual health team there. And you can go to the next slide. I just want to talk a little bit about our journey and our goal in virtual health. And one of the things that we try to do is to keep the patients closest to their home as they can, providing them high quality and safe care. And we believe that care is care. So, if you can receive care in your home, and we can do it in an efficient and effective way, a lot of patients have enjoyed that capabilities and have responded well to that. And there's good data on that. Our vision is to be able to establish virtual care delivery and make it consistent across our delivery model and throughout our system. Next, please. Okay. So Atrium has been on this the virtual health journey for about 11 years now, and we've started out with program development and have gone through many different emphases of the programs in that, where we would start with pilots and develop and grow and develop that. And now we're moving forward with what we call our Virtual Edge product, and it has a 20 plus different applications that we currently are offering. You can go to the next slide, please. And when we touch base on that, we touch base in the patient's home. We do post-acute, we do inpatient work. We do a lot of community-based work with schools and remote patient monitoring, primary and specialty care work, and then also on the emergency side, anything from doing urgent care to critical care assessments of patients and that. So we are basically running the gamut of virtual health, and we continue to grow and develop additional capabilities as we move forward. And I'll take it back to you, Lloyd.
Good deal. Okay, and next up we have Rick. So Rick, I will turn it over to you.
Thank you, Lloyd. Rick with Arrow Health, thank you for the opportunity to be in the discussion today. Looking forward to the questions that are coming. A little bit about myself and Arrow Health. I'm one of the co-founders of Arrow Health. Myself, as well as my partners, we often joke that this journey has been 2 parts personal, 1 part professional. For us, we all launched Arrow Health originally around family needs. For me personally, it was my father. For Dave, it was his sister. For Kevin, it was his wife. For Scott, it was his brother. And as we all sort of matured and grew families, we kept encountering lots of opportunities where we had shared frustration as well as desperation as far as being able to easily access and share our own healthcare information, or our father's or our children's. And so we set off with a very simple goal, which is to better position providers to have insight into sort of the day-to-day health and well-being of patients when they're outside of the clinic. For my father in particular, he has a pretty large extended care team. When we launched the company, he was newly diagnosed with Parkinson's, but he had multiple chronic conditions before that. And so going from one specialist to another sort of became routine. But as his health declined, even pre-pandemic, his ability to engage and truly get from point A to point B became a little bit more difficult. And so oftentimes we use him and his needs as the framework that if we can support providers and care teams and patients and their family members to be able to easily engage with their care team and share information, then it's a highly scalable blueprint. So that's a little bit about the personal side for what we're doing. Lloyd, if you could hit the next slide for me. Sort of core to our service offering, whether we're supporting providers that are in the ambulatory space, post-acute, truly meeting the patients in their homes. When the pandemic hit, we felt like telehealth really rose to the top for our core service lines, and also introducing it in a way that truly met the patient where they were, with an eye towards seniors. And so for us, we've helped support a telehealth service that is sort of on demand, easily accessible, and also is recorded so that multiple care team members can really get in the weeds of the conversation and continue that care plan. And the next slide just sort of ties it together. We have sort of a holistic approach. For us, COVID really solidified the need around monitoring the patient, not only from a device, but also around communication, whether that's a live phone call, telemedicine, secure texting. But once those engagements happened, how can we help the provider, the health coach, the spouse or adult child of that patient easily be able to collaborate on next steps and follow through on a care plan? So we bring sort of an agnostic technology stack that supports providers in all types of care settings. So that's what we have going on at Arrow.
Good deal. And how about you, Dr. Reyno?
Well, thanks, Lloyd, and thanks to GAHE for having us join this webinar. We're truly proud to be a part of this great group of panelists and to discuss what we really believe is going to be the future of medicine. And I have to echo, Kevin's statement that care is care. And really, when the evolution of our company, by training and by practice, I am a liver transplant surgeon. And so people ask me all the time, what is an actively practicing transplant surgeon doing in telemedicine? And it really, for me, similar to Rick, is a very personal story. I trained and I practiced at 2 of the top 5 hospitals in the United States every year in the U.S. News and World Report. And despite the fact that I practiced and continue to practice in some of these great institutions, I recognize that there's a real issue with efficiency inside of hospitals, and particularly in ICUs where we started delivering care. And for me, it was a personal journey at the beginning, simply because I was an end user and continue to be an end user. So I'm an end user of clinical services within the ICU, and I see on a day-to-day basis what the consequences are of costly and inefficient care. And so that's what really drove the impetus for us to start this company. And Lloyd, if you can turn to the next slide. I'll speak a little bit to sort of our end-to-end services, but really this is more a discussion of our journey within telemedicine and the journey for our company. we started off really as telecritical care a few years ago, where we wanted to create the most amount of access possible to hospitals throughout the United States who perhaps didn't have intensivists available locally in order to be able to drive care. So we wanted to make sure that our goal was to have every patient in every ICU across America to have an intensivist driving care in those settings, and not only an intensivist, but a critical care registered nurse. We started with a technology called eCare Manager, which is provided by Philips, and from there, our company evolved where we now are using our own technology platform, where we really try to focus on an environment where hospitals don't have the high capital expenditures in order to have a technology solution. So that was an important evolution in our company, and really it was really driven by the constant desire of trying to make sure that everyone has the same access, whether you're a hospital with a very big budget or a hospital with a very small budget. We just want to make sure that every patient gets the best care possible in those environments. And so from that point, we recognize that while we started in the ICU and we felt that if we can master care within the ICU, that we can master care in many other environments. And so from that point, we started providing other services. And it was really only because hospitals were asking us for it. And what we found was that our partners really were looking for multiple services, not just virtual critical care, but they were really looking for other services, other pain points that they were looking to solve. And in many instances, people said, we really want to have a telecritical care program, but our biggest problem today is that we don't have telestroke services or teleneurology services, and we're turning away all these people from our emergency room, and people are traveling 2 or 3 hours in order to get to the nearest neurologist at the big city, so to speak. And so we really started sort of expanding on our services to include teleneurology, telestroke, telehospitalist service, teleinfectious diseases, telenephrology, which I think is really, we were speaking earlier as to what the future of telemedicine will look like. And I think telenephrology will have a major component of it. And then lastly, telecardiology. And so from there, we felt like, well, okay, we're taking care of patients in the sickest venue of a hospital, which is the ICU. We're providing all these other consultative services that really support the tele-ICU program. But how do we really make ourselves a true end-to-end service and begin taking care of these patients who we're caring for in the hospital, in the step-down units, in the emergency room, and ultimately as they go home? How do we continue delivering care and delivering that highest value proposition and the best continuity of care? And so from that point, we've engaged with an RPM company where we're providing remote patient monitoring while Intercept physicians and nurses deliver care. An RPM company can offer us some infrastructure to help us do this. And then lastly, the final element that we've added to our company is really the data analytics. We feel very, very strongly that not only in taking care of patients, if you're not following the data, you're not really, you're not providing the cutting edge care, but also as it pertains to costs and what the financial value is to hospitals, not just the patient value to the individual patient. We feel that's equally important, and for that reason, we've added these QAPI programs to make sure that hospitals get the best bang for their buck, and that these services have all been added sort of stepwise as our company has grown. And happy to talk more and look forward to the questions.
Yeah, so thanks for that, guys. Very much appreciated, and just kind of gives us a little bit of an idea of kind of where our panelists are coming from. I think when you start looking at topics like this, as you can see just from the group that we have today, there's a lot of credibility that comes with the folks that we have and the physicians, and we're just living in kind of a different time right now, I think, from a healthcare standpoint. And I mean, I think we all can agree that the way we think about healthcare today is a little bit different, maybe a lot different for some than what we were looking at kind of pre-COVID time. And telemedicine's been around for a long time. I mean, it's nothing new by no stretch of the imagination. And a lot of times I talk about kind of why, maybe why did it take so long, or why did it take a pandemic to kind of get us to really thinking about telemedicine in that healthcare, or the technology and in the way it inserts itself into that healthcare space. And so let's go ahead and just start with some questions. And really the first question, and Dr. Reyno, I'm gonna go to you and then to Rick on this as well. And it's really kind of a multiple questions kind of rolled into one here. But when you look at the settings with the patients where the services are being provided, what type of settings are those? What type of settings are you seeing when you are delivering your services?
Yeah, that's a great question, and it is in constant evolution. Pre-COVID, remote patient monitoring was something that was really in its infancy stages, as no one was really doing it. And now, 2 years later, it is potentially the most rapidly growing element of telemedicine, and how we continue to deliver care outside of the hospital, which is in and of itself really a fairly new setting in the grand scheme of things. For us, as I mentioned earlier, we started in the ICU, but that has also expanded to, what hospitals are really looking towards is that in a resource constrained environment, how do we get ICU doctors working remotely to take care of ICU patients who are quote unquote ER boarders down in the emergency room, who can't make their way up into the ICU because of bed constraints, or in this day and age, which is even worse, because of nursing constraints at the bedside, where you can't bring a patient up because there's not enough nurses to take care of those patients. So we have adapted to be able to take care of these patients in different settings, in the ICU, in the emergency room. Another area where I see this growing very quickly is how we continue to take care of patients in the step down units, to avoid these patients bouncing back into the ICUs, and making sure that if they are bouncing back, that they're getting care at the, exactly where they are. They're beginning their care, whether that be in the step down unit, and really moving them when the bed is available and the time is right, and it's safe. So this is a constantly evolving scenario, but we find that both hospitals as well as patients, and most importantly their family members, are seeing tremendous value. They feel like someone is constantly watching, and someone is instantly accessible from a remote platform, as opposed to waiting for the bedside physicians who may be doing procedures, or really, and when you're working bedside, you can only be in one place at one time, which is truly the case, as opposed to working remotely, where you have the ability through technology to be in multiple places at the same time. And that's been a tremendous advantage for hospitals and patients.
Yeah. So now, Rick, with with your programs and what you guys do, how about your scenarios and the settings from a patient's perspective and a patient standpoint, I guess?
Sure. Well, core to our mission and sort of core value is always been really focused on servicing the rural and underserved communities. And so we had that focus pre-pandemic. I'm nodding and smiling a lot with what Dr. Reyno is saying, and then you drop that down into these rural or underserved communities, and access had been a challenge prior to the pandemic. And there were, several hurdles. It could be transportation. It could be just sheer distance between the patient's home and the clinic, and thinking specifically in the ambulatory setting. And so for us, that type of focus and approach really informed the type of technology that we were providing to these care teams. And so our focus has also been, if you drill down a little bit deeper, pre-pandemic, was the senior population, which I think got a lot of exposure, obviously, during the pandemic and has continued. And specifically, sort of the core conditions you may think of: diabetes, hypertension, chronic heart failure, obesity. And as the pandemic continued, we saw a door sort of swing open into the non-senior population. And we started seeing a lot more traction in the rural communities in particular, with patients that were either pre-diabetic, pre-hypertensive. They had some really active engagement with their providers that had flagged them as a rising, a member of the rising risk population, and just getting some simple things in their hands, a blood pressure cuff, a scale, a survey, something that is delivered to them, sort of meeting the patient where they're at. So being able to facilitate that through a cellular connection or a text or an on-demand video chat, we saw that really gain a lot of adoption over the last couple of years.
So now, and Rick, I'll stay with you right here. Was there a shift from in-person or face-to-face to a virtual for many of your patients, or were you already dealing with your patients in a virtual setting? So did the pandemic cause any type of shift for you guys?
A mix of both. So, I'm actually thinking about a clinic that we have in a pretty rural portion of Oklahoma. Like many practices, they weren't quite prepared when they had to shutter the clinic. And so they pivoted to the on-demand aspect of the telehealth visit. And what we saw was, that level of engagement they had not done before. So for example, they would have patients call in their blood pressures, or during routine visits, bring in a log, for example, of their blood pressure readings. And so there was sort of a steady stream of in-person visits and not really a virtual aspect to the care. The pandemic definitely, for that clinic, shifted it almost 100% virtual. And then as they opened back up, they sort of continued to isolate and practice a virtual care program with their high-risk patients, and we're getting some of their healthier patients back into the clinic. So it really created a runway for them to keep patients safe, get a much better level of insight into their day-to-day habits through, Dr. Reyno brought up remote patient monitoring, but we saw a pretty big increase in the telehealth aspect of that program as well. Yeah. So
how about, Dr. Reyno, how about with you guys and the program? I mean, I know you had a pretty large telepresence anyway, but did you guys see much of a shift in what you guys were doing?
So, Lloyd, and again, I'll echo many of Rick's comments, but, as they say, necessity is the mother of creativity. And so I'll take off kind of my Intercept hat for a moment, and I'll put my transplant surgeon hat on for a second. And as you mentioned, at Intercept, we're entirely a virtual company, but really taking care as a transplant surgeon working in a large transplant center in the United States, we take care of patients that really come from all over the country. Most of them, I'm based in Tampa, Florida, and most patients are from the West Coast of Florida, but there's a lot of patients that either come from Georgia or from even the Northeast. And as a transplant recipient, these patients, we see them once or twice a week in the immediate postoperative phase. And what we saw post-pandemic, just because we were forced to, because of the nature of the scenario that we were in, we were seeing a lot more patients purely virtually. And it's tremendously convenient for patients who are no longer driving 3 hours to come see us for a 15 or 20 minute, post-operative visit 6 weeks after their transplant. So it had several effects, which was it made our clinics far more efficient. It drove down our costs, and it was very well accepted by patients who really, we were just so dogmatic historically of saying we got to see the patients and touch them every single time, once or twice a week. And we realized that it's not necessary, it's not efficient, and it's not practical for patients in many instances. And so we have taken a lot of what we do into a virtual setting, but it's a combination. Naturally, we're obviously still seeing patients in our clinics, but we've taken a lot more of a virtual approach to care.
Good deal. So Kevin, I'm gonna move to you here with this next question or two, and it's really kind of talking about the technology, because we've seen so much of a change in the technology, and like I said, telemedicine's not new. We've all been in the technology, this telehealth space for a number of years, so we've all seen some of the technology kind of advance and change. But talk a little bit about how you've seen the technology, and how, moving into this pandemic phase, how you feel like it assisted the patients. There's a myriad of technologies out, but talk a little bit about what you've seen from a technology standpoint.
Sure. There, like you said, telehealth's been around for a long time. Telestroke and other modules have been out there for years, and if not a decade or so. And then, these usually required access to a cart or something like that, where someone would move the cart around and they'd be able to look at the patient, get the patient's stats and information and that. But things have changed quite a bit. There's a lot of platforms that are out there. Most of them are cloud-based. So the information is provided easily to the people. They can access the applications easily through the internet. Virtual programs can be implemented on a smartphone. It doesn't matter if it's an iPhone or Android, but those applications are readily available to people, and it's made it so much easier for people to go from having to, as an example, a person who's working in that and has kids, and one of their kids gets sick, and so they have to take off time of work to go to take their kid into an ENT or something like that to see what's going on with the ear infection and those types of things. Now they can actually do a virtual call. They can do it while they're at home with the child, and get those taken care of with 10 to 15 minutes, and then the physician can prescribe that information or prescribe that prescription and send it to the pharmacy right down the street. So it's much more convenient. People aren't losing time at work, and it's become very people are very satisfied with it. Prior to COVID, there was it was probably 10 to 15% nationally of people said that they would use telehealth. And there was a recent survey that I seen about 3 months ago that basically said 82% said that they don't want to go back to going into the office if they don't have to. And if they can do it virtually, they would rather do it that way.
Yeah, and you talk about, when we think about this whole technology piece, and you look at technology over the years, I started a little over 11 years ago. And, I remember my first, and I come out of a technical background, but I remember my first kind of when I started, and I come into the office, and the gentleman there was kind of showing me the equipment. Of course, it was a telemedicine cart, on wheels, and monitor and pan tilt zoom camera, I think a Cisco codec. And so I remember, I'm sitting here looking at this and learning it. And I remember when we got talking about the price, and I'm like, so how much does one of these cost? And it was like $30-something thousand. And I'm thinking, my car don't even cost this much, and of course that was a hindrance for a lot of the advancement of telehealth. And I think it kept a lot of people kind of out of the game, maybe on the sidelines a little bit, but as you talk about, Kevin, with the technology and what we see today with, readily accessible with smart, with our smartphones and our personal devices and everything. It's just kind of neat to see, where it has come over these years, and to some degree that technological barrier, that maybe that cost has driven down. And I think that allows people, that opportunity to kind of get involved. And I think that's kind of what we're seeing. We see that with the whole direct to consumer model of telemedicine. now where people are just, connecting up on smartphones. I still feel, there are, some limitations. And I always like to tell people too, I always lay this caveat out, telemedicine, and I say this, is not a cure-all. And it's not a fit for every scenario. It's not meant to replace physicians. There's always going to be that need, but it is a great tool. That technology is a great tool in the tool belt for physicians and practices and facilities and so forth and so forth and so on. So Rick, on with this next question, I mean, when we look at telemedicine, and listen, there's a lot of ways that we could peel this onion back, but talk a little bit about some of the technical requirements that you have to take into consideration from both ends, right? Because it's not just one way. I mean, you got to think about technology on both ends. So what are some of those technical requirements that has to be taken into consideration when you start looking at developing telemedicine?
Sure. Great question. I'll actually start with the patient. And the reason I'll start with the patient is you could arm yourself to the teeth in investing in the best technology on the provider side of the relationship. But if it doesn't work at the patient level, it's kind of all for naught. And so we look very closely at the friction points that could occur at the patient level. And so I think you just made a comment that really resonates for me. Having the ability, for example, to access a telehealth visit from your phone may work really well for you or me or many folks attending here on the call. But, that's not something that is easily accessible for somebody like my father or many of the senior population. And those seniors might be a little bit more comfortable engaging from a computer, especially if they have a family member that's assisting them. So, sort of the punchline there is meeting the patient where they are at and being able to engage them in the technology channel that is familiar and comfortable to them. And so that could be having the telehealth, the access token to the room being emailed to them, so they don't have to take it from their phone. It could be issuing them a medical device like a glucometer or BP cuff that is not Bluetooth dependent. Maybe they don't have a consistent Wi-Fi access point, especially in a rural community, or dependent on their own personal device. So having a device that has a SIM card that's built into it, that their RPM program can just pick the data up off the cellular feed, I think is critical. Just as much as you can wick away the need to have a patient adopt new technology that requires them to go into app stores or things like that, and just allow them to focus on the engagement or taking that reading or vital, I think is really critical. And then on the provider side, oftentimes the first thing that we hear or see or even observe is just the login fatigue. And so, creating yet another technology platform for a provider or their care team or their staff or a health coach to log into when they're already sort of in swivel chair rotation as it is. They're in their EHR, they're in, a pop health portal, name the technology. We feel and have seen rapid adoption of a telehealth solution when you incorporate it into the native clinical workflow of the EHR. And so oftentimes, there's great solutions out there that do sort of the back end connectivity, but also just kind of baking it into the front end and giving that staff member access to everything that they need for that care plan, whether it's RPM, like Dr. Reno brought up, or it's the telehealth visit or access to their chart. I think the more that you can provide telehealth solutions directly into the view of the EHR, it just creates less friction points on the provider side as well.
Yeah, good points. And so, Kevin, also wanted to kind of look to you on this as well. From that technology standpoint, what are some additional considerations that you might bring to light?
I agree a lot with what, actually, I agree with everything that Rick said. And there's a lot of one of the issues that we currently strive to try and to deal with and to fix, and it's not a really easy fixable problem, is those patients that are in our hospital at home program that were sick and in rural areas that don't either have reliable access to internet or don't have viable phones. And so how do you deal with that? How do you what are the problems that you have to deal with, and what do you do with those types of patients? And there are a lot more of them than we realize. If you look at the map that actually, I think I received it from you, Lloyd, that talked about the bare spots in the southeast of communication spots that have no broadband or very limited cellular. Those are the issues that we have to figure out and have to deal with, and so we end up sending community health workers or community paramedics and that out to these patients to deal with them and to bring setups with them so they can actually have the virtual visits, because they're not accessible from those locations. So it's a matter of trying to figure out what's accessible, like Rick said, and what's available for the patient, what they feel comfortable with. And then when they don't have those accesses, to try and figure out what you can do to help them alleviate those. And what we're doing now is looking at different options for cellular, and then also looking at ways that we can actually get people out there to help and assist those patients.
Well, you bring up a very good point, and what we've seen, and we did kind of a sort of a best practices type deal with some FQHCs across the country. We participated with some other TRCs, and one of the things we found, and I think a lot of people maybe didn't take this into consideration when you're delivering services to patients, is taking the patient's location into consideration. And so screening the patients on the front end proved for some FQHCs to be a game changer, because just making a call and saying, hey, what kind of bandwidth do you have at your house, or do you have home internet, or what kind of technology do you have for us to connect up, is very important. And that became one of the best practices, is doing a screening on the front end with patients to get a better assessment of the technology. Because Rick, you made a good point too. Not every patient is a good candidate for telemedicine services. I mean, I think about my mother was the same way before she passed away. If she had to rely on a virtual call with a physician, it would have been very dicey. She still had a flip phone. Everybody, we just assume, I think sometimes, that everyone has a smart device, and that's not necessarily the case. So very good points, guys. I think one of the big issues that we're seeing, Kevin, you alluded to it, when I sent out that broadband map, one of the things here again that COVID, I think, really shone a light on and put under a microscope was just really how inadequate some of our locations are when it comes to bandwidth. And at the end of the day, telemedicine can't advance, and telemedicine can't move forward and won't be successful if we don't fix some of the broadband issues that I think we're facing. But that's actually a whole nother conversation that we could have. I do want to move on just for the sake of time. So Dr. Reyno, I was going to get you just to talk a little bit about, we talked about the equipment and some of those requirements. Talk a little bit about the cost. I mean, when we start, looking at some of the financial things that come into play here around telemedicine programs, just what are some things that need to be taken into consideration there as well from a cost standpoint?
Yeah, I think so. Cost, obviously it's always the 800-pound gorilla in the room, and but it is something that I'm actually personally passionate about, and I think most people that are in telemedicine or providing some telehealth service look to cost as really to demonstrate what the value of this is. if you start considering, starting a telemedicine program or a virtual care program of any type, generally speaking, you're going to have staffing costs, you're going to have technology costs, both hardware and software. You're going to have management costs, and you're going to have implementation costs, which, the technical implementation is in many instances a very big portion of the costs associated. But what I encourage, our hospital partners, and what I also encourage people that are in the business, is to really kind of look at what is it exactly that you're getting for the costs, and to really build out a clinical program that is not only going to drive better care for patients, but is also going to generate new revenue opportunities for hospitals. And that's something that we truly look at very carefully anytime we're looking at one of our potential hospital partners. If you're a hospital that is not admitting patients into your ICU with an acute MI because you don't have an intensivist to take care of those patients, then these are potentially lost revenues, and patient out migration often tends to be a big problem in scenarios where specialists are not available for individual hospitals. So it's a financial problem for hospitals, but it's also a tremendous hardship for patients when they're being shipped to the big house, so to speak, in the big city. And so, what exactly are you getting associated with the costs? And so I think it's about really building a valuable program that is valuable to the patient. At the end of the day, if you're providing good care is cheaper than bad care. So proactive care that is really conscientious and looking at the patient in a continuous fashion will tend to be cheaper in the long run. So as far as the the upfront costs in the financial considerations, what I encourage is to try and minimize a lot of the capital expenditures and try to operationalize costs. And really, as we've been discussing, a lot of the technology solutions that exist nowadays is not as it used to be when telemedicine first started, is that there was these big, heavy technology platforms that were really CapEx significant. So now there's opportunities to really limit the CapEx. And then finally, I think if you're focused in an inpatient setting, if you're focused on best practices, how do we get patients out of the ICU more efficiently? How do we minimize complications? All of this will decrease the overall costs. And what the literature would suggest, at least in the ICU, is that having a telemedicine or a virtual critical care program will decrease the cost of each ICU admission by $5,000. And so, while there may be some upfront capital costs or associated with starting different types of programs, the long run is certainly better care for the patients and also cheaper care for hospitals.
Yeah, and Rick, I also wanted to go to you to see if you had anything to kind of add into what Dr. Reyno said.
Yeah, I think he nailed it. But in addition to that, what I would say is, oftentimes I feel like for smaller independent clinics or, a clinically integrated network or an ACO, there is sort of this baggage, this historical baggage that healthcare technology has applied. And so working with your partners to take on some level of risk. I mean, the cost of technology has decreased so much. And so a lot of times it's starting with a program that has low cost, quality devices that don't necessarily have to be bought up front, and that can be easily adopted by the patients, and then sort of build off the program from there. I'm also a very firm believer in, recognizing where the practice is. Oftentimes the staff, no matter how big or small, is already stretched really thin. And so the thought of applying a new program can be overwhelming. So, having proven assets and resources in the community. We did we're at the tail end of an early AFib pilot, and so in addition to the device, we partnered with a really strong group of consultants that really were able to come in, mirror the culture of the practice, and become extenders and take on a lot of the work that would traditionally hit the nurses while keeping the providers informed, and also engaging with the patient. So, it's a collaborative effort. And so I think cost aside, it's coming with people to do some of the work.
Yeah, and that's a good point. And I tell you, there's a hospital in South Georgia, and when you would hear them talk about their telemedicine program, their virtual program, the neat thing they would always talk about was the downstream revenue. So not, so often I think we focus on the upfront costs, right? Because we look at the technology and we look at, there was in the chat here, someone talking about the buy-in. There's those hurdles, that you do have to overcome. But I think if you can get to a point to where you can look at the downstream revenue, so where programs like telestroke and tele-ICU and think about technology being used, and Rick, you kind of alluded to it some with some of the devices that you can maybe send home with patients to monitor when you get into remote monitoring and things like that, that could ultimately cut down on readmission costs. I mean, we've all seen what those numbers can be when you start looking at readmission and things like that. So here again, so very good points. And here again, moving on, because we want to make sure we get through more of these questions. One of the big questions that I get on quite a bit, it really revolves around credentialing and privileging and all that. So Kevin, I had you kind of pegged for this. So I'm going to kind of let you tackle it. What do credentialing and privileging guidelines and those regulations, like we see, with CMS but not necessarily CMS, when you look at licensure, across the board and the credentialing, those type of things, what does that mean when you have to take in those things into consideration from a regulatory body when you look at telehealth?
Yeah, so Atrium is providing services in North, South Carolina, and Georgia, and then most recently in Alabama. And the unfortunate part is that there's the state compact, but all the states aren't in it. So it negates that. So you end up having to go through the process of relicensing all of your physicians in each of the states. And so that process is long. And then after you get the license, then you got to go through all the credentialing, which is both hospital and payer credentialing. And, that whole entire process can take, 9 months, sometimes longer. And during COVID, it was accelerated because of the PHE that several of the states allowed physicians to get emergency licensing. And those were effective, and it alleviated some of the tension. But when that goes away, and it will go away eventually, those changes are still there. So if anyone from Congress is listening, nationally, what we need to do is to have some national legislation that allows physician licenses to transition from state to state. And that would be very beneficial to be able to
sort of like VA physicians, that they have that ability. A VA physician can practice, state to state. So
right, correct. And so that is something that is it takes a long time. It costs a fair amount of money, and those licenses are renewed either annually or by every 2 years. And so it's quite a bit of an expense, and it takes a whole team of people to get all this work done. But eventually it's worth it once you get it all settled and you're operating your telehealth systems. But it's a process to go through, and recently too, CMS is they've extended their PHE, and they changed the rules to allow telehealth in certain settings for reimbursement that they never allowed before. The big question is, what are they going to do after the PHE is over? And I think we have a good hint that the train is out of the chute and it's running down the track, and so I don't think they can pull it back. But will they keep it at the same level, or will they curtail some of it? Those are questions that we don't know yet, or answers we don't know yet.
Yeah, and I will say this. So probably one of the most, asked, or one of the most, topics that I get when people call me and they say, "Hey, Lloyd, I'm a physician, in X state, but I'm seeing patients here, and can I do that?" And I think what people sometimes fail to realize is licensure. From a licensure standpoint, it follows the patient. So licensure, you have to be licensed in the state where the patient is at the time of service. And so, some of those things were relaxed, but now, as you alluded to, you've got some states where the public health emergencies have expired, which in turn ended some of those flexibilities. Now, I will say this too, you do have some states, Georgia is one of our states, and Florida, they have created like a virtual license. And, I don't want to go too deep into this, because here again, we do things on, you can do an hour on licensure alone, but Georgia and Florida do have a virtual license that an out-of-state provider can actually apply for a virtual license. You can't practice physically in that state, but you can actually practice virtually. So I think that might be a pattern that we see move forward, say in the absence of a national licensure, Kevin, which you alluded to. And so I think some of the issues that we see from a telemedicine standpoint that I think we're facing is, telemedicine is governed at the state level, right? So in other words, outside of Medicare now, but when it comes to telemedicine, Medicaid, and reimbursement, things like that, all these policies, they're all done at the state level. And so sometimes that causes a little bit of an issue too, but all right, so let's
It
kind of
does.
move on. Go ahead.
I was just going to, one more comment. I was going to say it does, because the laws change from state to state, and Georgia actually has been, had done some really good work in legislation, and the law that went into effect on July 15th of this year was pretty progressive and has allowed a lot of good things for telehealth, but it's not necessarily the same in some of their surrounding states.
Yeah. All right. So let's look here, kind of continuing on. Rick, how might telemedicine services play a role in the provision of healthcare in the possible future? So, from a provider assuming greater financial risk, for patient care. So I'd be interested to hear your thoughts there. Let me repeat that. So how might telemedicine services play a role in the provision of healthcare in the possible future scenario of providers assuming greater financial risk for patient care?
I think we are definitely seeing this evolve right now. We're absolutely seeing it. So I'll give a few examples. I think where I'll end up in the answer is it's going to push providers to, I think, embrace and truly explore more of a virtual care program. And I don't know that there's one silver bullet per se, but depending on the complexity and the health of their overall patient population, we've seen a lot of progress in shared risk or risk-based agreements over the years. Then if you look at Medicare in particular, just from a sheer patient volume size and the risk that's going out, kind of moving from MSSP to direct contracting, I think we're seeing that. And so I'll give a couple examples that are pretty recent for us. We have a group in Mississippi that really embraced telemedicine and started wrapping around remote patient monitoring, as well as chronic care management for specific segments of their patient population. And when they brought in a provider group to kind of help scale them, again, staffing in a rural area is pretty difficult for them, and they service a really large patient population. So, having those telemedicine visits and engaging with those patients where the technology allowed them gave them more time and more sort of discussion points with the patient. So what I mean by that is, for some of the patients, I think I'm not a provider, but I look at it and I think I overlook the intimidation factor, or sometimes the white coat effect. And so if I look to my dad again, he shows up and he says everything's fine, he's eating well, he feels great. That's not the case. But having that interaction in the comfort of their own home, and being able to stand up and show the doc what they're talking about, paired with glucose readings or blood pressure readings or oxygen levels, it starts to develop a trend. And we have this group in Mississippi in particular where they have enabled health coaches to really get into the weeds with their patients around their daily living habits. And so, what might seem like a simple task, but not possible within the four walls of the clinic, is on a routine basis, reviewing their grocery list. Are they on plan? Are the patients comfortable enough to call them and let them know what they're going to go shop for, and this is what they're going to eat? And so, following the trend line of dropping blood pressure, glucose scores, all of those play a factor into, depending on the health plan that patient is attributed to or tied back to, that provider probably already has an incentive to prevent that patient from hitting the ER in the example that you talked about before, or elevating from a stage 4 to a stage 5 in their diabetes profile. So, I think that telemedicine is a really unique way, unique in the sense that it wasn't that widespread prior to the pandemic, but the population got a lot more comfortable with technology, FaceTiming with their grandchildren, Zooming with friends and family members. The embrace of it, I think, is pretty obvious. It helped accelerate some of that. And so getting that access point in the home, I think, is really critical to potentially head off an adverse event.
Yeah. So we have about 6 minutes left before we just kind of open the gates here for Q&A. So Dr. Reyno, kind of in a little bit of I guess what we consider moving towards a close down here. Let's just kind of envision, let's say you've got the magic 8 ball and you can see into the future. What do you see? And I don't want to just pinhole it to telemedicine, because I think sometimes we do an injustice by using that term telemedicine. But what do we see as healthcare with this whole idea of technology? Because technology has a way of inserting itself into our lives. And I say this all the time. If you look at every aspect of our lives, technology has inserted itself, whether it's in our vehicles, our homes, our jobs. It just seems like healthcare was late to the game, and maybe that's policy, maybe it's adoption, whatever the reason. What do you see moving forward for this, for the technology and that marriage of technology and healthcare?
I think technology and healthcare working together is going to, without a doubt, in my opinion, drive better outcomes for patients in the future. And it will drive access. I mean, if there's one term to walk away from today in this conversation, I think we all agree that access is the greatest benefit of this. But as it pertains specifically, I think patients will have access. A patient in rural Georgia will have access to a specialty type of surgeon who can give a second opinion or provide advice from a different state or even a different country using telemedicine. I think that's where we see the future of how telemedicine will bring better care for patients. As it pertains to risk, I think patient care will get better, because what we will see in the future is that technology will drive individual practitioners to make sure that patients who have a hemoglobin A1C that's greater than 7, there will be a risk-based model that will have consequences as far as reimbursement to physicians. So there is going to be some inherent risk associated with that, but technology will help drive for those patients to get better care and for someone to be monitoring remotely on a real-time or near real-time basis. So I think that's where the future of telemedicine will move, and how technology will complement it.
Good deal. Awesome. Well, I tell you what, guys, you know, my alarm just went off. I had my alarm set, so I think we're probably safe to turn it or to open it up for Q&A. I know there were some questions in the chat box, but I believe you're going to have the option too of unmuting your mic, and so I'm going to kind of turn it back over to the GAHE folks, and I'll let you provide any instructions that you wish to provide at this time.
Lloyd, I put the questions we have so far in your chat. So do you want me to ask them, or do you want to ask the questions?
No, I can ask those. Let's see here. So
should have about 5 questions so far.
Looks like if labs, okay, so I'll just open this up really. If labs are needed to send out a technician to the home or send the patient to a convenient lab. So let's see, if labs are needed, do you send them out? Do you send out a technician to the home or send the patient to a convenient lab? And I'm not sure if that's directed at anyone. So if any of you guys maybe can respond to that. Or if someone wants to, whoever asked that, if they want to unmute and maybe ask directly or elaborate a little bit, feel free to do that as well. So I think the question really revolves around, do you send a technician out from a lab standpoint, or are you sending, or do the patients go to a more of a convenient lab?
This is Glenda. I can elaborate a little bit on that. I asked that question. I was just wondering, since our focus is on keeping the patient or patients in their familiar surrounding, if they need labs drawn, do we send a technician to the home to draw the lab to keep them at home, or do we send them to the nearest laboratory to have them draw the lab, like Quest or one of those?
Good question. Do one of y'all want to tackle that? Dr. Reyno, I see you unmuted.
Yeah, I think I can speak to it a little bit, and it's really from personal experience. You know, there are companies that exist out there that we personally don't do this, but there are companies out there that will send a tech to your home, to the home. But naturally, it depends on the scenario and also precisely what the acuity or you know, exactly what program you're working within. So, for instance, if you're really working a heart failure program through a remote patient monitoring system, you can certainly, obviously what we do in those scenarios is to, you know, weigh patients on a day-to-day basis, and we gather a lot of information that way. But there are some labs that we do like to see from time to time, and in those instances, depending on how you design the program, you can really do both. But there are companies out there today, if it was your desire in the development of your program to have people come to the patient's homes, especially the elderly population who may not have a way of making theirs, you know, making a way to LabCorp or to Quest, et cetera. There are ways of getting technicians out to the home to get labs drawn.
All right, another question. Can orthopedic surgeons utilize telehealth for post-op visits?
I think I'll answer that one just because I think I have probably a little bit more experience in this, even though I'm not an orthopedic surgeon. But the answer is absolutely yes. So there's actually some pretty neat, interesting technology that exists for specifically for orthopedic surgeons that has 2 functions actually. Firstly, on a global scale, orthopedic surgeons, just like a transplant surgeon like myself, you can gather 90% of the information that you need to do a physical assessment and a complete assessment of the patient through a two-way audiovisual technology of some sort. So that's the very first sort of broad concept that needs to be understood. Specifically as it pertains to orthopedic surgeons, there's actually technology out there, for instance, for patients who have had a total knee replacement. There's a technology out there that utilizes some hardware in the patient's homes and actually does range of motion exercises on a day-to-day basis with these patients. And all of this information is being tracked into a software platform that's delivering the information in real time to an orthopedic surgeon at home. So every day there is a progress being tracked as to that fresh post-op patient who just had a knee replacement, that we can now see that previously they could only flex at the knee, say 45 degrees. Now they're able to flex, 65 degrees, and you can actually track the patient's progress from not only from an orthopedic standpoint, but from a physical therapy standpoint, using a combination of hardware in the patient's home, as well as software that is giving the orthopedic surgeon and their team all the information through a software platform in their offices. So that's just one specific platform that I know exists and is out there. But generally speaking, orthopedic surgeons can gather the same information that any other physician can gather as well through remote means.
Good deal. Thank you, Dr. Reyno. Another question: has anyone had experience with using telemedicine in pre-anesthesia testing, in the pre-anesthesia testing environment, using the platform for the patient interview, pre-op, education component? I think probably along Dr. Reyno's, response earlier, I think that can be done. I think that might come to a policy standpoint too. I think sometimes you can run into policy, but I think as far as like pre-op appointments, I think those can be done. Anybody want to shed some light on that?
I'll just comment. I have no personal experience with this, but I think it's a great idea. And I would say that the technology clearly exists. I mean, PAT, testing, well, obviously set aside the lab testing for a second, but, PATs really consume a lot of resources inside of a hospital. And it is truly something that can be done completely virtually. Using some fairly simple platforms, you can do a complete interview and a full physical exam, even listening to heart and lung exams on a patient who's being screened for surgery, and to do the educational component of PATs. The technology is out there and exists to be able to do that. I mean, again, if we can do heart lung exams on ICU patients that are intubated, we can clearly do this in a PAT setting. The technology exists, and Brian, I think that's a great idea, and will really help you flex resources within an inpatient setting.
Yeah, I think the thing that would need to come into consideration that you would want to look at, and it gets a little bit in the weeds, would be from a reimbursement standpoint. So you would just need to check out from because here again, what we deal with in every state, you have different reimbursement policies with your various payers, what Medicare allows, what Blue Cross will pay for, what Medicaid will pay for. So I mean, that would be the technology definitely exists. I think my only thing I would say to that would be just make sure that it's something that that's reimbursable. And you get into so many. I mean, when you start looking at reimbursement for services, for virtual services, you get into inpatient, outpatient, bundled services, and all these various type of things. So that's one thing I would just say you would want to look at and take into consideration. So. All right, next question. Great discussion. In my experience, clinical adoption with health technology can be a huge issue. Many times the behavior of a few select providers can sink an implementation. What strategies do you embed into your technology, workflow design, or evaluation methods to help combat this pain point? So I think really the crux of it is how do you deal with with clinical adoption in an instance where maybe maybe you've got a few who are not on board with it. So anybody?
I'll just provide a comment. We've seen this a lot too, especially prior to COVID. There was a lot of people that were hesitant, saying that they didn't think that their patients would want to do this, and that they didn't think it was the best source of medicine or their time. I think those things have, in the past 2 years, those ideas have changed quite a bit. But I would highly suggest that you find a person that does want to do this, that is a person that you want to use as your champion, and rely on your champion to have those physician or provider to provider conversations. And that's one thing that's going to help you drive your program.
Rick, did you want to add to that?
Yeah, I'll add. I think that's also spot on. I would also say that, coming prepared with sort of a rubric. So sort of what's the framework that would provide a successful pilot program? What's the quality and the clinical ROI? If there's a financial ROI, that's part of the equation. And just having that really visible, found that for folks that may be extremely challenging when it comes to adopting this, having a lot of transparency around programs that have worked well and seeing if it aligns with what they're trying to achieve, sort of in the beginning stages, goes a long way to gaining buy-in.
And I'll say this too, I learned early on. So we would always go in, like if we were standing up with my parent company, if we were standing up say a telestroke program, we would always have the opportunity to be in front of a lot of your clinical, your neurology groups and so forth and so on. And I would start out with my PowerPoint, my presentation, and I'd be going through, and you got your neurologist sitting down on the front, and he no more wants to be there, than a man in the moon. You could tell it. But the moment we went into a live demonstration, because we would always do a live demonstration, and the moment we would go into the live demonstration and we would show that connection and we would show the devices and what the technology could do, I mean, the light would go off, and it was, from that point on, it was nothing but conversation. So I learned early on to put that live demonstration on the front end to provide that education piece, to let them see what we're talking about, and what can, how the technology can, can really assist, and what the technology could do. And I'll tell you, that changed so many times. I would not even get through the rest of my presentation because there would be so much conversation and so much interest. And so I think sometimes it's to a little bit of an education point. But I'm going to go back to what Kevin said. I think, it's very important. Have that clinical champion that you can have on the team who can champion that. And it's very important. So we got a couple minutes before I turn it back over to Trent to shut us down. And it just says, much like in credentialing, the PHE opened up channels for reimbursement of telehealth. What does the future of reimbursement kind of look like when the PHE is over? Who knows, right? And that, I think we all agree that's kind of the what is that, the $1 million question? So,
I think if we knew that, we could make a lot of money.
Yeah. I'll say this, or go ahead, Dr. Reyno.
No, I mean, I think, that's the big question, but I will say the following. The Pandora's box has been opened here. We're not putting it, we're not closing the box again. And so in this today, prior to COVID, areas of the country that were recognized as critical access areas could bill one-to-one for services that were being provided remotely at the same as they were being provided at the bedside. But you had to fulfill some certain criteria, and you had to be in a really an area of need. Since the PHE, now all of the billing is happening at the bedside at the same rate with the same codes as that care that is being delivered remotely. Having said that, I think that the future we will see, probably my suspicion is that we will see a downward adjustment for telemedicine services, but only in all likelihood somewhat of a slight downward adjustment. It won't match what is being done at the bedside, but I still believe that we're not going back to a place where there was no reimbursement for telemedicine services. I think that is here to stay, but I suspect there will be some adjustment, slight adjustment to what is currently happening at the bedside.
Yeah. And I'll follow, just to close out, I'll follow with this. We're in a state here in the state of Georgia who has been pro telemedicine for a number of years. We've had policy that legislates or mandates legislation that mandates reimbursement. So in our state, and we were one of the early adopters to do that. So in our state, payers are mandated to pay for telemedicine services, but it's still, there's still a lot, in that. I mean, that can be done. So, and then when you look at Medicare, because Medicare is of course a major player, it's going to be interesting to see what Medicare looks like once the public health emergency ends. So there's a lot of things that's being discussed. There are a couple pieces of legislation at the federal level that will affect Medicare reimbursement that's kind of worth watching out for. One of them is the Connect for Health Act. So you can check that, follow that. That's probably the one piece of legislation currently that has the most bipartisan support, that if passed, it will make sweeping changes to the Medicare reimbursement, because the way it's set up currently, once the public health emergency ends, you've got waivers that will cease. And so once those waivers cease, a lot of those changes that were made to the Medicare reimbursement will cease as well. So there's some policymakers that are trying to keep those changes in place. But right now, it's kind of a wait and see, a watch and see what happens. And I think that's just kind of where we are with the reimbursement thing. So with that, I've got 1:25. I'm going to turn it over to Trent, and I will let Trent close us out. But thank you panelists, and thank you guys for allowing me to moderate. I think Trent probably should have said, instead of saying I had a BS in this, maybe I think what he heard was I have a degree in BS maybe. So anyway, Trent, I'll turn it over to you, bud.
All right, thanks, Lloyd. Appreciate that. I never would have thought that, but and if I did, I wouldn't have said that to you, buddy. But again, what a great session. I look back just in these past 18 months, 20 months now, just what telehealth helped us to do, and the evolution of telemedicine over these past 20 months, and then how we're moving forward. And I totally agree. Our organization couldn't have survived COVID without telemedicine. And going forward, I see only a bigger spot in place for how we can virtually bring our physicians to the bedside. So really kudos to you, Lloyd, and thank you for moderating today. Thank you to the panelists. It's great to hear from a group of experts in the field as we're all navigating these waters together and trying to best serve our patients. So thank y'all so much for that. Big kudos to our, I think Matt phrased it as the A team, not to make any comparisons, but we had the A team of committee members involved here today: Matt Enright, Bobby Ryan, and Angela Henry. Thank you for putting this, organize this event today. And then big special thanks to all of our sponsors. Really appreciate our sponsors and what you do to help us, again, put sessions like this on consistently. So, and I'm already seeing, throughout the chat, just a lot of great feedback. So again, couldn't have gotten this group together without our amazing sponsors. And then another special thanks to ACHE. Again, we were on the forefront of offering face-to-face credits here at Georgia Association of Healthcare Executives, and Ricardo and team continue to provide that support. So really appreciate that. You will get a survey emailed to you, so please take a few minutes just to give us feedback. Again, we've got great feedback on the chat line, but would love to hear from you and any ways that we can make these kinds of events better. We want to know how we can do that. And then just really last but not least, thank you all for your leadership across the great state of Georgia. It really is amazing to see how our hospitals and our leaders in our hospitals are stepping up in a big way. All the vendors that we work with on a daily basis, how much they step in to support us. It's really just one big team that helps to provide amazing care to our patients in our state and beyond. So thank you so much. All right, and that said, I will turn the mic over to Ricardo to close us out.
Thank you, Trent. On behalf of AACHE, I want to thank our chapter leaders that planned today's session, the moderator, and the panelists, and all of you for your participation. Please complete the evaluation, which is open for 1 week. The direct link is in the chat box. You can also access the evaluation by visiting your My AACHE page and selecting My Online Learning from the helpful links section on the right side of the screen. From there, click on the Access My Courses link and you'll be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within approximately 2 business days. Everyone who has attended today's session in its entirety will see their 1.5 hours of face-to-face credit posted to their My AACHE accounts within 2 weeks of this session in the My Education Credit section. That concludes our session. Today's program is copyrighted in 2021 by the American College of Healthcare Executives. All rights reserved. Thank you for attending and be well, everyone.